A decubitus chest is typically somewhat difficult to do. It is usually used for patients that are unable to stand. So I will have brought my patient in on the gurney. I will have them either roll up towards me or away from me, depending on the view that the radiologist has asked for. So I'm going to have Heidi turn up on her side. Okay. Then I'm going to start getting all of my equipment ready to go, because I generally want them to be on their side for about 5 minutes. That allows all the fluid to fall down and the air to rise up, which is what we are looking for. So I will come over here. I will bring my tube down. Okay. I'm going to have a vertical central ray. I want to be at 72-inch SID for the chest x-ray. And now I'm going to go around and I'm going to start tweaking to get her into position. So I'm going to come around here, and I want to make sure that my gurney is locked before I do this. Some gurneys lock better than others. I'm going to bring her back towards me as far as I can get her back there. I don't want her to fall off the edge of the table though. Okay, so I'm being very careful. I'll put her up against the wall bucky, and again I will lock my gurney. I will come back around. I'm going to go ahead and shield her. Okay. This hand needs to be up above. I want her to be as lateral as I can. This arm can either be up or down. Up actually works better. And I'm going to enter about T7. Okay. So again, I'm going to spend some time tweaking my gurney to get her to where I'm entering about T7. Okay. I need to bring my tube head down here. Okay. Now I need to make sure that my wall bucky is lined up to my tube. So I'll come back around. Okay. Okay. I want to make sure that I'm getting the top of the apices of the chest and all the way down into the costophrenic angles. My marker is going to go on the body side. So this is her right side. So the marker will go right up in here. Right marker, right side. I'm most interested in, however, in the bottom side. So this is an exam that's specifically looking at the left side. This would be considered a left lateral decubitus, even though and so that's why my right marker is up here, because I'm just marking my body side. I'm going to tell her to take in a great big deep breath when I'm ready, to blow it out, and to take in another deep breath and hold it in, and that's when I would take my film. I'm going to use a 14x17 IR because I want to get as much area as I can. Go ahead and breathe. And that's how I would take that film. Okay, I'm going to demonstrate a decubitus abdomen this time. This again is for a patient that is unable to stand, but we want to see air fluid levels. In this particular case, we're not going to shield the patient because that will obstruct the area that we're trying to see. So I have brought the patient in on a gurney. For this one, the radiologist has asked me to have the patient turn away from me. So we're actually going to be doing a right lateral decubitus. So I'm going to have you turn towards the bucky. Okay. I'm going to have the patient get as close to the gurney or to the wall bucky as they can. Okay. I want them to be as lateral as they can. Bring your arm up above your head. Okay. And I'm going to have my central ray right at the level of the iliac crest. So I'll bring my tube head down. I'm going to have a 40-inch SID, so 40-inch right here. And now I'm going to start doing my tweaking. Okay, want to make sure that you lock the gurney after you've moved the patient. I'm looking for my central ray to enter right at the iliac crest. Okay. My tube is aligned to my wall bucky already. There we go. Come back around. Okay, we'll roll her up. And I'm going to enter, this one's actually easier because I can actually center right to the middle of her spine. Okay. I'm going to open up my collimation so I have a little bit of light right over the top. Okay. My cassette or my IR is actually going to be in crosswise. I am going to mark the upside. So this is her left side, so I'm going to put a left marker right here at her left side. Okay. I'm right at the level of the iliac crest. My wall bucky and my tube are lined up, she's lined up, and that's how I would take a decubitus abdomen. I'm going to demonstrate how to do a dorsal decubitus. Typically this is done for abdomen films. However, I have seen it done occasionally for chest. Basically, when you do these films, you want to bring the patient in on a gurney. You're going to get your tube actually lined up with them first, and then you're going to do all the rest of the fiddling. This is kind of a difficult exam, and it takes a lot of tweaking to get it right. So the first thing that I did is I'm at a 40-inch SID. I have moved my tube down so that my central ray is entering 2 inches above her iliac crest, and I'm entering right in the middle of her body. Okay. Checking. Okay. Then I'm going to move around, and I'm going to move my bucky so that it's lined up with my tube. Okay. And sometimes that requires moving the gurney a little bit. You want to get the patient as close to the bucky as you can because, again, you don't want a huge air gap right here. Then I'm going to have the patient bring their arms up above their head. Just move them up like that. Perfect. Okay. Again, I'm 2 inches above her iliac crest. For most patients, because this is an abdomen, you're not going to do shielding because the reason that you're doing these is you're looking for aneurysm or hernias or masses. So my bucky is now lined up to my tube, both crosswise and lengthwise. I'm going to make sure that I have the correct body side marked on my IR, so her right side is closest to the bucky, so that's the side I'm going to mark. That's where I will put my marker. Okay. Okay. The other important thing about this particular position is that you collimate down as much as you can. You want just enough light so that you're basically skimming the top of the abdomen because there's a lot of scatter involved with this film. So the more collimation that you can do, the better. And then you don't want to collimate off of your IR. So you're just covering your IR from this side to this side, but you're collimating down this way. And once that is all set, then I'm going to lock my gurney, and I'm going to tell the patient that I want them to take in a deep breath. I'm going to have them blow it out, and I'm going to take the exposure on expiration. That's a dorsal decubitus. Okay, Heidi, we're going to do a lateral abdomen now. So you're going to be, most of the time you're going to be up on your left side because that's typically the routine that is done everywhere. Okay, so I'm going to rotate you up because I want you to be as flat as I can right there and as even. Okay, you're going to position the patient about 2 inches above the top of the iliac crest. So this is just a little bit higher than your traditional KUB or your prone. Okay, and again, you want to make sure that you get both you're mainly interested in the anterior portion of the patient, so you don't want to make sure you cut off anything in the front. Okay, make sure your tube's detented. Make sure your cassette is lined up to your tube. Okay, marker goes right behind her. Okay, One nice thing you might want to do is just put a cushion between their knees. It just makes it a little more comfortable for them and actually makes them a little more lateral. So that's just a hint. Okay, again, collimating as much as you can at a 40-inch SID. Okay, and that's how you would do a lateral abdomen.
This view is similar to the dorsal decubitus, only they're able to roll up onto their side. So same criteria, diaphragms as much as possible, diaphragms and as much of the lower abdomen as possible, air-filled loops of bowel, soft tissue detail, no rotation, and no motion.